Thank you so much for joining today. I have my dear friend and colleague, Erica Sutton, Dr. Erica Sutton, here with me today. I met Erica at ELAM program where both of us did a leadership course for the last year. And I was so excited to get to know Erica and both of us getting to know in this leadership journey. And we realized we have so much we could collaborate as Creighton University, Morehouse University, Common Spirit, CHI Health, and so much to learn from each other. So thank you so much for coming. A little bit background on Erica and her expertise. So she graduated from Indiana University, triple major in psychology, chemistry, and mathematics. Very impressed. And she joined Johns Hopkins University for School of Medicine. She completed her residency in general surgery at University of Maryland, followed by fellowship in minimal invasive surgery at University of Maryland School of Medicine, department in Baltimore. And currently she serves as the inaugural Associate Dean for Academic Programs and Affiliation for University of Morehouse School of Medicine. And today she'll be talking to us about how to build an inclusive environment in academic medical settings. So please welcome Dr. Sutton.
Thank you so much. Thank you for the opportunity to come and talk about this today. I recognized as I was trying to pare down my slide deck that you have given me the opportunity to speak about something I'm passionate about. So I'm committed to moving through. If you see me watching my watch, it is just to make sure that I leave time for discussion. Thank you for that lovely introduction. The other part that I'm going to say, in addition to my role in medical education, is that I've had the opportunity to really lead the Morehouse School of Medicine efforts in our partnership with Common Spirit. So when Morehouse School of Medicine is working with Common Spirit, we are called the More in Common Alliance, and that involves our school and that involves you. So you are also more than welcome to ask me questions about that work and how that really kind of plays into some of the things that we're doing here. Oh, thank you so much. Usually,
yeah. Technical difficulties, give us just a second. Okay, there we go.
Great, thank you. So I have nothing to disclose. So I usually like to make sure that I've done just a little bit of level set. Because before I worked at Morehouse School of Medicine, I don't know that I could have told you some of the things about the historically Black medical colleges. There are four. The first was founded in 1868. That's Howard University. It's located in Washington, D.C., followed by Meharry Medical College, founded in Nashville in 1876. Then Charles Drew College of Medicine, which is just outside of LA and Watts, founded in 1968. And then we're the newest, Morehouse School of Medicine, that was founded in 1975 in Atlanta, Georgia. So I always try to make sure that I both wear blue and I kind of explain the difference. When we started in 1975, we were a 2-year program sponsored by Morehouse College. Morehouse College is the all-Black male institution. Let me say that it's an all-male institution that is historically Black. So our 2-year program started there, and our graduates would finish their medical degree at Emory. In 1981, we became a 4-year program, and we are the Morehouse School of Medicine. So I say this because you'll see the large media outlets get it wrong all the time. We are blue. We do not have any undergraduates or a football team. And if you see burgundy or tigers, that is the all-male school. Now, I'll tell you, we are literally all within 2 blocks of each other. So usually, if you're looking for somebody there or looking for a partnership there, we are all part of that same group. When you're talking about those 4 schools, Morehouse School of Medicine, Morehouse College, Spelman College, which is the historically Black all-women's college, right between Morehouse and Morehouse School of Medicine, or Clark Atlanta University, we're called the Atlanta University Center, or AUC, or you might see AUCC. And you're really speaking about 4 historically Black colleges and universities that are in downtown West End of Atlanta, Georgia. I think I did it. 'Cause- so I put this in here to talk about briefly Vanderbilt and the historic alliance between Vanderbilt University and Meharry in Nashville. And for anyone that has kind of been in the Midwest or followed that, it is a very strong 10-year partnership between the two institutions in which students from Meharry can take any courses that they want from Vanderbilt, fourth-year students, and vice versa for students from Vanderbilt can take any fourth-year courses from Meharry. It's really important because sometimes when you're doing something new, like the More in Common Alliance, to remember that there are certainly versions of collaborations and partnerships like this that exist and that have been done before. I also always put up there, just in case you hadn't seen it, and because I think that it can change, I'm going to show you in a slide that this has even changed, but it's the concept of underrepresented in medicine. And so historically, when we're talking about URM or UIM or UR lowercase IM, we're talking about these groups. But I want to show now what is really an attempt to categorize the many different ethnicities and definitions of URIM. So this is the new 2021 data. And if you look at the column on the left, you can see that there are now multiple versions and ways to be Black, multiple versions and ways to be Hispanic and of Latino origin, and even more than one way to be white in this new, really kind of catalog. I think that's very important because as we're looking at both these numbers, but we're also trying to track and follow our concepts of diversity and ethnicity, that we recognize there are not two diversity categories, there are not three diversity categories, and there's a generation of people that may not choose to be categorized. And that takes place along lines of ethnicity and gender. So I'm actually very proud of the AAMC for really stratifying the data this way. However, I also would like to point out that I chose the matriculant data, not the applicant data, because it tracked pretty well. This shows that still of the roughly 66,000 applicants to medical school for 2021, that they are still primarily white or Asian, and among those categories. This is new data, and I thought this was actually very novel and very impactful. But what it also says is that the vast majority are still very well resourced. 70% of students applying to medical school come from a household in which one parent has either a bachelor's degree, a master's degree, or a doctoral level degree. And that if you don't have a parent with that level of education as a surrogate for socioeconomic status, it's much less likely that you are going to even be among those who are matriculating into medical school. This is the matriculant data. Actually, the applicants are on here too. They put all of this in one slide. You can see at the top. So I start with some lessons from surgery because it's my field and we had some really big gaps, some really big disparities to talk about. It is no surprise then that underrepresented minorities, those who are underrepresented in medicine, were also underrepresented in those who were being even selected to interview in surgical specialties. And the data was striking. This is from the previous paper. The next two slides were from that same paper. If you're looking for the reference and tracking, that though only 50% of the applicants in surgery were white, they comprised almost 2/3 of those who were selected for interview. This means that if you're trying to create a diverse residency program, you have taken a step backwards before you've even selected anyone from your program, just based on how the selection process for interviews was taking place. And so the reasons were multifactorial. I put this number out here because that was the reason that a lot of programs were using a cutoff, a step 1 score or a step 1 cutoff. And so you can see here that there was a disproportionately high number of applicants with scores below the mean, and the mean continues to rise. 220 is actually a fair bit below the mean now, but there were a disproportionate number of students who were underrepresented in medicine who had scores below 220 that we felt were biasing perhaps that interview selection process. So what are some high quality processes that could address these differences? Modifying the screening tools, using a selection team, and developing a structured interview format for your interviews. So I first wanted to talk about, well, wait a minute. What is step one's been used for a long time? Was it never good? Did it never tell us anything helpful? And what we found when we looked at 20 years of comparing step one scores to clinical evaluations, board pass rates, is that yes, step one tells you something. It tells you how people take a test, and that people who can take step one well are most likely to be those who are going to take other standardized exams well. However, you can still pass that standardized exam regardless of your step one score. Was really only 50% predictive in who was going to get favorable faculty evaluations. And so that while I don't think that you can say it's irrelevant or it didn't tell us anything about an applicant, it certainly should not be used as a sole criteria for screening in or out an applicant for your interview pool. And this was Dr. Aaron's approach to shaking up diversity in his residency. Okay, they used a program that first gathered data, and I'll talk about this a little bit at the end, which was first understanding the institutional level data for his program. 23% of its student body was from a group categorized as underrepresented in medicine, yet 7% of the surgical residents were from those categories, which means there was a large gap between who was there in their medical school and who stayed for their surgical residency program. So they started, like any scientist would, with a good literature review on what can be done, what are some best practices to create a more inclusive environment there. No surprise, there was very little data there. And so in terms of what exists in the literature, there are now a few things like Dr. Aaron's program that are out there, but otherwise, best practices are generally derived from expert opinion in this area and in this field. You'll see a couple of things that are a little bit more like his program. So they started with a visiting clerkship program. This has become pretty standard, across the country now, to have a visiting clerkship program, a 4-week visiting clerkship for underrepresented medical students. They came the summer or fall, the audition season for the rotation. This was back when the stipend could be $1,500, and we kind of go back and forth about that even in our partnership. Okay. Meaning this is an experience where students are now receiving compensation for doing medical school work versus are you paying preceptors, and are you supporting the clinical experience and site with institutional resources? So then as a medical school, what are you paying the students, and you're paying the preceptors, and you're paying everybody to have an experience. But it's an important thing to talk about, that fourth year students were collecting stipends and are in many cases collecting a stipend for these experiences. Now they are meant to offset the cost of travel and housing. And so $1,500 at this location, which was funded by the division, may have been appropriate. In New York, that's very hard to find anything for 4 weeks, at that rate. And then they advertised regionally and nationally to really recruit students to their program. Step 2, they used a holistic review of their applicants. And I won't read holistic to you, but immediately I was like, what is that? Can you tell me more about what that means? Because it's one thing to say it, it's another thing to have to actually prepare, implement something that is a holistic review for your faculty. And so very specifically, this information was helpful. It first began with faculty development. And so that meant that GME sponsored symposia, workshops, speakers with experience and unconscious bias and UIM recruitment, very important, as well as UIM trainee retention, very important. So offering some form of regular faculty development in this space and in this topic. Programs were provided tools to implement holistic review, asked to abolish or review some of their criteria, such as USMLE scores, or to, consider how those are weighted or utilized in the selection process. And then resources from the AAMC can be sought and utilized in implementing holistic review. I'll tell you the biggest crux of that appears to be unconscious bias training. And then it was a targeted outreach. And so they organized for house staff. And essentially you may hear of this in hospitals as an affinity group. And so they created an alliance of minority physicians that were focused house staff, junior faculty, medical students to support the mentorship at UPenn and provided support to applicants. So before interviewing at UPenn, contacting with the candidates during their interview day, and follow-up communication after the interview if desired. Now, this isn't you come into UPenn, this is how was your visit? Do you have any other questions that you wanted to ask of the program, or maybe didn't ask that day, or maybe didn't feel comfortable asking, or think you might get a different answer, in a one-on-one conversation. So it was really kind of that approach. I started to show this slide for two reasons. One, it's to celebrate an outrageous success in diversifying his program. And to say that this was national news and certainly praiseworthy. The other thing that's very important on this slide is a picture of Dr. Ahrens, because I came from a program that was 50% women in surgery training that had a female program director, Barbara Bass. And so I think that the secret sauce to this article is, what does it mean to have people who look like you in leadership positions in that program? And that it's not a bad step to start there. You might want to immediately diversify all your training programs, but if your leadership or your program faculty are not diverse, that may also be an important first step to doing some of these other things to diversify the program. Okay, so again, I think that Dr. Ahrens' work is to be celebrated, but also to understand that there's another intangible on this slide, that even if you have a visiting program that's offering $3,000 a month and using holistic review criteria and all those things, to understand that you could still be missing a piece of the puzzle here for learning. I wanted to talk about what's experienced in residency, and I use this scenario again from my own field, especially if you're talking about stuff that could be sensitive. I try to pick on myself and my friends first. But this was part of a survey. I'm proud to say that I participated in the survey and now have joined two of its investigators in the study group to diversify the surgical workforce, Drs. Yo and Sosa. This was taken after the 2018 ABSITE. And I, again, filled out the survey, surprised to know I was only one of 5% that did that. But this is the importance of perception. This is the perception of students by ethnicity for surgical residency. And look at the significantly lower numbers for happy when at work, fit in well at the training program, and can count on other residents to help out. They feel as though they get along with their fellow residents, and maybe some slight statistical difference there, but can count on other residents to help out. And that's very important, because I think that has to do with also your ability to recruit. That also has to do with your ability to, can you see? Thank you. Your ability to recruit as well as to retain these residents, okay? Why do they hold these perceptions? Sorry, if it wasn't my mom after her cath, I would not have had to have that answered. Of course, she would call during the talk. This is Dr. Lynn Weaver. He was the chair of surgery at Morehouse School of Medicine. and recently passed away. And I've included this link because he has an amazing StoryCorps that I think is very, very insightful about his experience playing football as part of a team in the segregated US, okay, in the South. And I put on there because I've both learned not to rely too heavily on video in a talk, but also because I have, plenty of slides to really talk about the perception that he shared, because I think it really echoes what we see in the data. And that's normally when you're with a team, you feel like everybody's going to stand together, but he never got that feeling from his team that they would stand with him if things got bad. But one of the very profound things that I think is in the StoryCorps from NPR is that he said, I think a number of the white students who were there with me would say now, if I could have done something different, I would have said something. But that's what evil depends on, good people to be quiet. And so in these conversations, we have to remember that every person who comes to the conversation is a good person and wants to see something that doesn't currently exist. It is very tempting to assume or worry, feel concern or mistrust about intent, but we have to keep having these conversations because otherwise the opposite will both remain and worsen. So understanding that having these conversations about inclusion are what has to be done to move the needle forward on those. If these are perceptions, are they, and if there are these differences in perception, are they disparities though? I think that's an important question because I could be thinking that I won't be received or won't be treated equally, but does that make it true? Or does that actually create a difference in how I am treated? And so I think that if there was any meat and cheese to this whole talk, it's in the next couple of slides that talks about what are the differences in perception, what differences in perceptions are disparities, and how does that relate? So what makes a difference a disparity? It's when it carries a disadvantage. There could be lots of differences, but if there's no disadvantage to it, it doesn't necessarily mean that it's a disparity. And so having these perceptions and holding these perceptions, is that a disadvantage to students who are underrepresented in medicine? If you have a perception that you will not be received well, treated equally, are you at a disadvantage because you hold that perception? And I thought this was, it both resonated with personal experience, with observation, and my everyday work with students who are underrepresented in medicine. And that is the impact of marginalizing perception. It translates into a reluctance to interact, to sometimes seek help when you need help, limitations accessing those academic resources, such as academic support, discomfort when participating in group discussions, study groups, fear that one's actions will confirm an existing stereotype, also known as stereotype threat. So if you believe that your classmates perceive you as not as smart or got in because they're trying to diversify the class, but you really have a very low MCAT score because you're not as smart as everyone, you might not speak up to get clarity on material because you're afraid that you're going to confirm a stereotype that you don't have the knowledge to be there, okay? That poor academic performance on exams or on assignments that could be due to negative impacts on concentration and emotional well-being. So if you're concerned about these perceptions, if they cause anxiety for you, if they interfere with your ability to concentrate, then that can lead to poor academic performance. Internalizing of negative messages. And I think that really kind of underlines some imposter syndrome that you see, and ineffective coping, such as disengaging, avoidance, and substance use. And I can tell you in my now 8 years as a UME leader, I've seen all of those to the nth degree. I would say they could also be very true in our resident space. Avoidance is the most common, but disengaging and substance use as well. And I think the pandemic worsened that for many students as well. So marginalizing perceptions can be disparities if their impact is not addressed. And I think that's important because that gives us a place for action. That gives us a place to target in terms of creating an inclusive environment, is to looking at those areas that are impactful and addressing them directly to level that playing field and welcome all to that learning space. Okay. I'll give this example. I'm shorter than the average surgical resident, okay? Is that a disparity? I mean, I feel targeted, but it's a difference, though not presently a disparity because the table height goes up and down. They'll bring me 2, 3 stools, 3 steps if I need to. That difference does not confer a disadvantage just based on my height. However, female laparoscopic surgeons are receiving more treatment for work-related injuries to their upper pectoral girdle. That's wrists, shoulders, thumbs, in the setting of fewer years of practice. Is that a disparity? That's a disparity because female laparoscopic surgeons are experiencing disability or disadvantage and a threat to professional longevity. Okay, more surgery, more treatment, time away from the OR. So I want to look at this disparity because whether we're out of the pandemic, back in the pandemic, never really were out of the pandemic, wherever we are, it doesn't feel like it's over. And the question is, how were underrepresented in medicine applicants affected by the pandemic? Well, the first impact was in eliminating, then restricting away rotations. That is very impactful for underrepresented in medicine students who may need that network of away rotations to be seen for their clinical skills, who need to be seen for what they can contribute as doctors outside of their reading in a book and taking a test. And so that immediately became a very impactful difference. I'll tell you that Morehouse School of Medicine that doesn't have a hospital, doesn't own a hospital, is very reliant on these partnerships for our clinical experience. Similarly now, Thomas Jefferson's another good example of a hospital partner that went away. And so then Drexel became very reliant on those clinical partnerships. And when all of a sudden, those partnerships and those clinical experiences were reduced, that was a disadvantage for the students in those programs. Virtual conferences is a plus, yet there were fewer research activities. But again, that's another way for students to distinguish, to both develop their interests in academic medicine, but also to set themselves apart as candidates and applicants. And so when there were fewer research experiences, that was a disadvantage. Although virtual conferences, that is an advantage, as are the virtual platforms that were presented for interviews. So more virtual platforms cause increased access and lower cost. So really, those were some of the main impacts. What is not known? What are we still sort of looking for the answer to, which is, were greater percentages of underrepresented medicine applicants selected to interview as a result of now having virtual platforms or able to accept those interview invitations. And I think programs are just now kind of starting to look at that data. Excitingly, I think the AAMC is asked to continue virtual interviews this year. And they made that decision even before some of the more recent spikes that we've seen, but it has to do with that level playing field for the interview format, which is why then I sought best practices for that interview format. You know, what are the disparities or what are the high quality practices to make that an inclusive environment? So I really thought that the anesthesiologist had the best literature that was available here for this, which the mainstay that I thought was train your interviewers. And again, it's back to that unconscious bias training. Train your interviewers. We all have conscious bias. We all have conscious bias. I'll tell you, Morehouse School of Medicine, we're 76% African American, 6% Asian, about 3% white. We all have a conscious bias. You know, look for the other isms. Is it ageism? Do you think that an older student can't do this job? You know, I mean, all of those things. And so the rest of these, there's 3 more tips. Go virtual for everyone. Showcase your program. Do your unconscious bias training. Do a practice. Plan for glitches and act like you would in person. I thought this was really helpful in terms of how do you create an environment that is inclusive for socioeconomic bias. So our diversity categories don't necessarily follow the lines of ethnicity. Ours follow socioeconomic status, geographic area from which they're served. They come from a medically underserved area, you know, Black males. And so as a school that does look for and attend to socioeconomic bias, we have to make sure we consider connectivity for our students. We try to standardize our interview so that you're not giving a slightly different interview to males or females based on your unconscious biases. And that setting isn't everything. Not everyone has access to private, quiet, well-groomed space. And so whenever possible, whether you are a residency program or a medical institution, if you are willing to offer space for people to do interviews, that actually is something that you can do to create an inclusive environment for them, their interview setting. So lastly, I wanted to talk about who's going into medicine and are we starting early enough? Are we looking in the right places? And so I thought it was really important to bring forward this quote about minority medical students' perceptions of careers in academic medicine and what that means to them. So they expressed an early interest in academic medicine, but really weren't sure how to go about it. How do you get to work at a Creighton University for your career? And their perceptions of having greater difficulty in accessing that career can be an obstacle to engaging in the prospective pool. So this quote from a young woman said, "Seeing a person who looks like you in that position makes a goal like that much more achievable because you might face similar obstacles. I have never seen a professor of color. Why aren't they there? Where are they? Why aren't they there?" And I think that it's an important question to ask. It's an accountable question to ask ourselves and each other, and to receive the answer without judgment, but only with the goal of taking action. So in that action, one of the things we've seen across institutions is creating JEDI initiatives, justice, equity, diversity, and inclusion initiatives or committees or task force. And this is really a welcome response to some of the social justice movements that we've seen in the last 2 years. I think that we also, both HBCUs and PWIs, that's shorthand for primarily white institutions if you hadn't seen it, we need to seek diverse opinions. So we want to invite input from someone outside of the department who also works in UME or GME, include an institutional DEI officer. We have had a diversity, equity, inclusion officer at Morehouse School of Medicine for less than 12 months. And I think that there was the mistaken assumption that we didn't need one until we really recognized we needed one. You know, so that has been a welcomed addition to our school and our work. Search out someone who is not within your specialty, maybe someone who is not an MD that also is going to be a diverse perspective. Exchange tips, pitfalls with another undergraduate medical education colleague or another GME colleague, and then ask for feedback from a colleague, maybe from another institution or from your networks. I have gotten some of the best feedback on my work from people who are not in medicine or, not involved, because they're going to see it completely differently. Whereas I may be using a script that I think we're all playing from, and this person might see that we have been particularly exclusive, maybe of somebody whose first language is in English. So I think that seeking feedback from a colleague outside of that space is also very helpful. And this, we really challenge our own institution around, which is around data. To do this with evidence, decide what data you are going to collect, who is going to collect that, because if you don't have a clear sight on who's going to collect data, it is very easy for one individual or one office to have other priorities. And so really institutionalizing the who is going to collect data, when, at what intervals. Is that going to be continuous? Is it going to be quarterly? Is it something you only need to look at once a year? That will be an answer for your own institution. Data quality and safe storage. I've never seen data just maintain itself in a high quality manner. I wish I had some like that, but I'm always having to really look at how it's getting input into our learning management system, how many different categories and codes and labels I have that really mean the same thing. So you have to have a plan for data quality and storage. And such that if you change systems 3 years later, you haven't lost all your data. That's what I mean by storage. Monitoring, a comparative analysis strategy. And usually that, as an institutional level, involves policy creation around what you're going to compare and when. And then reporting and sharing, which is very important. Who's going to get reports at what interval, and how broadly is this information going to be shared? Is it internally? Is it externally? Is it only at the level of the dean staff, or are you giving this only to chairs? Or then who is going to look at this data and be accountable for responding to that? So these are the slides. I do also like to take a little moment in history, because Dr. LaSalle-Lafall is a wonderful example of a lot of things we've talked about here today. And it also, sometimes there may be icons from another culture that everybody seems to know about, but if we don't share their story, you may not ever know who Dr. LaFall was and what he means, I think, to generations of Black doctors. So Dr. LaFall recently passed away as well. He's a surgical oncologist. He reports 3 very early influential factors in his life. He had a family friend who was a physician. He had a touching encounter with a dying bird, but mostly he really had the support of his family and unbridled encouragement. I say that because it's free, because unbridled encouragement isn't about a private school, or it's not about the resources that you could buy. He had unbridled encouragement from his father and his mother and school teachers. And they taught him that he could overcome his obstacles. And that remained very important to him. He said his father told him, with good education and hard work, combined with honesty and integrity, there are no boundaries. And he turned that goodness into greatness. He graduated from high school at age 15. He graduated from college at age 18 in 1948. This was not an inclusive time for Black males in America. He didn't score well on the MCAT and was rejected from Meharry. I at Morehouse make sure I remind them of that often. But he was accepted to Howard University College of Medicine. And the dean at Howard and the admissions committee decided that with his college grades, he would do well in medical school and admitted him. And he graduated first in his class at medical school, which he started at 18 years old. He became the first African-American president of the American Cancer Society and the first African-American president of the American College of Surgeons in 1995. And is known for saying that excellence in performance will transcend the artificial barriers created by man. I share this story too when my students are both stressed about the MCAT or devastated about their score, that there's no one score that defines anybody. It certainly didn't define the career trajectory of Dr. LaFall. He said that he believed his parents and he believed Dr. Charles Drew, that the barriers they talked about were segregation and discrimination. But if you do well enough, it doesn't matter your race, ethnicity, your religion, people will notice your hard work and accomplishments. He said, I took that to heart. So I think that it's very possible. Let's cultivate an educational culture that recognizes the differences experienced by people who are underrepresented in medicine. Trainees ensure that they are not disparities or barriers. They remain only differences. And that as educators, we are noticing the hard work and accomplishment, not only in the form of scores or publication count. So I like to thank the many mentors and peers who taught me that all of me, especially my differences, bring value to our shared work. Thank you so much. Any questions? Is there anything you'd like to talk about? I think that that's going to create a greater advantage to people who can do the in-person visits. And so that's why that first square was do all virtual, or do the same for everyone.
Erin, will you repeat the question for the people on Zoom? We weren't able to hear the question.
Thank you so much. Yes, for reminding me. The question is, we'd love to be in person again. And the AAMC is recommending that we continue to do virtual interviews for this year. And what are schools saying or thinking about a strategy that involves having virtual interviews, but in-person opportunity? And I was really referencing that very first square that said, do the same thing for everybody, because the in-person interviews are going to be an advantage for people who are able to make it in person. And we know that. We know that by our desire to be together and to be in person. There is increased access, but meeting someone in person and being able to, as humans, acknowledge their facial expressions, their nonverbal affirmations would be an advantage.
So I have a question.
Yes.
So from a program residency standpoint, if your residents aren't passing boards, it looks really poorly on your program. So at least, I don't know about surgery, but in medicine, if you drop below 90%, that's like a cutoff where people stop ranking your program. And as you pointed out, doing well on the steps is an indicator of doing well in future multiple choice exams. So how do you see getting around that, or what would your recommendation to programs be on that?
I'm going to make the same recommendation at the UME level and at the GME level, though the action looks different. And that is, there has to be an acceptance and commitment of resources to developing those learners. In the UME space, it's usually academic support, and it's often placed under student affairs, who are taxed with a continual calendar of activities, but really creating space for academic support. You'll see that this comes up as a search for learning specialists. I've seen that kind of that job description pop up now quite a bit. I will tell you that for our residents, that looked a little bit different. It looked a little bit more, because they don't have nearly as much available time for study. And so it had to be some focused and deliberate board prep that was led by our IM program. Because we saw that same data come across for our IM program. And particularly when our programs were newer, and the composition of training was more diverse, we had to have more board prep.
So an institution has to be committed to that too.
Yeah. And it's, I said acceptance first, because that's the whole cultural conversation that has to say we want diversity, and we understand that supporting diversity looks like academic support. And academic support costs money. And sometimes, even within my own institution where we are ethnically diverse, I have to just let that conversation be felt. I'll tell you a great example was paying preceptors. My leadership didn't want to pay them. And I had to just set the culture that doing this for altruistic purposes is no longer the standard, and that preceptors are expecting compensation across the country now. Sometimes you have to do that acceptance piece first.
Thank you. And great talk.
Thank you.
There's a good question in the chat.
Yeah, let me read it off of here because they can hear me. Okay, let me go on. As an African-American program director, I've noticed that the challenges of differences causing disparities seem to be even more profound for our male African-American residents, particularly the issues with speaking, I went too fast, with speaking up and stereotype threat. Can you help me get that? I added the threat, but I think that was. Yes, you sure? Okay, I got it. Yes. Do you know of any strategies to help with this? Academic support is always a challenge for programs. Board prep can sometimes be one of the, move that down gently. I'm going the wrong way. Okay, it can be one of the first things for institutions to cut. It's absolutely true. So there is a crisis happening in one of our surgical specialties, and that is orthopedics. It is a very dangerous place for Black males because it's actually, and particularly in that specialty, it's rarely strictly an academic problem. An ability to take a test. As you know, the board scores required to do orthopedics require that you can take a test. It is very much about culture. It is very much what you refer to about speaking up. And so one of the things that we instituted about 2 years ago is to have an opportunity for Black males who are applying to our residency programs to come back to like a second look that is specifically for them. And it was incredibly well received. I think it was also incredibly supportive and created a network of support for them. At our institution, males are the minority gender. And I think that this was a wonderful idea by our then DIO, Yolanda Wimberly, to offer that opportunity. It was really kind of an affinity group opportunity. And so I think because it's more than just academic support that's needed here, we have to also address really some important perceptions, some important differences in how they are received and treated by hospital staff, nursing staff. I think that you have to address that culture, and maybe one step could be an affinity group that lets them support one another. Thank you. That's a very good question and a very difficult question. Yes, sir. Yeah. Yeah, absolutely. So there is like fresh emerging literature that's coming out about step 2. And the reason the literature on step 2 didn't exist before is because we were all using step 1. and nobody was really, and neither students nor faculty were really saying much about step 2, except it didn't go down a whole bunch. And so now there are a few papers about what's going to happen now that step 1 is pass fail. Is step 2 going to be the new step 1? Yes. Yes. What's that going to do to the step 2 scores and means? They'll go up. I mean, I think that it's good that there's literature out there about that. I think it's worth reporting. I think when I'm looking for that, I'm looking for cross sections for both gender and ethnicity, just to see what's happening. But it's pretty new because step 1 just went past fail in January. And so first the conversation, and we're just now getting the data because that group is still has scores. The majority of students from which the data would be derived still has scores. And so those who just have taken since January are literally pass fails just coming out. They haven't taken step 2 yet. So more to be had on that. So that's why I asked my question. Tell me more about that. What does holistic review mean? I have to tell you that at a minimum, I like for it to mean you've done some unconscious bias training. Now, I think we've all been, or many of us have probably been on selection committee meetings where everybody in the room has been required to do this unconscious bias module, and you come to the meeting and the biases are just a flare as big as ever. So we know that we're not done there. The next step that I like to see in holistic review is some effort at like standardizing the interview, whether it's an interview book or it's a set of questions that we're going to ask. And the faculty development piece, the training piece. What are your nonverbal cues that show bias to an applicant? Smiling and affirmation, which you can do virtually and send across virtually versus checking your email while they're talking that says I'm not interested or I'm not making eye contact with you. So those to me are the things at a minimum. I will say in this space and in full recognition of pending lawsuits across the country for criteria, how do you rank a program or a school? I think you have to be very careful if you are creating a holistic review that gives so many points to public service or so many points to publication, or the idea is to say, as a department, we value community engagement. We value public service. And so if we see a score that has us concerned that someone would be able to pass the board exam, is there something else that gives us an indication of this person's focus, commitment, and ability to follow through on a long term, or looking for some other ways to say that. But I don't have a list of you've got to have public service, because that just becomes the same, sort of checkbox, or, oh, you don't have 40 hours, you only have 32 hours of public service. So I at this point kind of focus on the faculty development piece. Yeah. Yeah. Yes. We saw that our students were spending a lot of time as caregivers through this pandemic, taking care of family members who were ill or siblings who sometimes financially couldn't support themselves. And that was very impactful for our students. That to ask them to drive into campus when gas is $5 a gallon, it sometimes really kind of set off what would be unexpected, almost triggers. It was kind of a tipping point throughout that. I'm just going to make sure I've seen all the questions in the chat. Yes, great, thank you. Yes, sir.
there were fewer requirements that were
Yeah.
coming from the ACG programs in this area. And I was kind of glad to see that experience in Tom's world. You would be able to say something like, why did I do this? Giving some experience on that departments there, where we were able to substantially increase the diversity of our resident class. We're going to do this.
Yeah.
We work on sometimes say more Spanish people sometimes. So enforcement significant expansion speaking population, and people don't have to be mental health. So why do you think the difference between how the two different
uniquely I understand it because of understanding and having to work to understand a little better what both accrediting agencies are asking. One of the things that I felt was at the heart of what the LCME is asking is not that you have to reach a threshold number, but that you have to have a process that demonstrates you recognize the value of diversity to healthcare, but that you are showing that your adherence to that process. Not that you have an outcome, not that you actually successfully recruited 10 Black students, but that you have a process in place that ensures you have a recruitment effort, that you're not simply only advertising in affluent areas and things like that. And the spirit of that accreditation is, are you following a process that supports diversity within within those fields? I think with the ACGME being less familiar, but certainly, kind of recognizing the need for that. I think bias was more influential in the residency interview selection process and subsequently in those who were offered jobs. And we also know that involves, did the residents like you? How did you feel like you fit? It's a match process. And so fit and match, which are rife for the influence of bias, were in those spaces. And as the GME accreditors are working through some of those, I think it's a recognition of where that process is, kind of as opposed to UME and some of the LCME requirements there. So anything else? Any other questions? Thank you. That was a great question. Well, it's been my pleasure again to be here and to see this beautiful campus. So thank you so much.